I have a case out here that has isomerism of the left atrial appendages, and we can see that on short axis. As we reviewed with our morphologic characteristics yesterday, with our sequential segmental analysis, if we look at the appendages on this short axis view, here we can see the right pulmonary artery passing behind the aorta to the right lung, and you can see that there was a common atrioventricular junction. The right-sided appendage is finger-like with a narrow junction to the atrial vestibule. You can see the pectinate muscles here are mostly confined to the appendage with a little bit spilling out into the vestibule. And the left-sided appendage, again, is finger-like with that narrow junction to the atrial vestibule. And the pectinate muscles here are confined to the appendage. This case had bilateral superior cable veins. The right one has been cut away, but the left one has been retained because you can see it's draining to this very large coronary sinus here, to the left-sided atrium. There was a right-sided inferior cable vein. So all of these venous structures can be quite variable, and I'll show you a couple of cases. Actually, this one looks like it had hepatic veins to the left-sided atrium and an inferior cable vein to the right-sided atrium. So we'll go through the cases that I brought and show you all of the variations that we can see. This one had a common atrioventricular junction, but I brought this short axis just to show you how nice we can see on this echocardiographic view from the base of the heart how we have bilateral morphologically left atrial appendages and a smooth vestibule all the way around. So I have a case with the liver attached. I do have one right isomerism with all of the organs attached. These, we try to leave most of these cases intact for teaching purposes. They travel okay, but they weigh a lot because they have multiple components. So here, if I lift up the heart, you can see I have the liver attached, and it looks like a pretty normally shaped liver with the smaller left lobe and the larger right lobe. This case did have a right-sided stomach, and there was no spleen. When we look at the posterior aspect of the organs, we can see that there is what we would call possibly the caudate lobe of the liver. The gallbladder was extremely hypoplastic and directly in the midline. And you can notice on the back of this liver, there is no fossa or depression for our inferior cable vein. So this case did have azygous continuation of the inferior cable vein. So there was interruption of the hepatic portion so that the abdominal organs drained via this large azygous vein, which returned to the right-sided superior cable vein. And you can see here was a left aortic arch extending down the left side of the spine, and the azygous vein was along the right side of the spine. This patient had normal branching of the brachiocephalic arteries. There were bilateral, bilobed lungs. Lower lobe, upper lobe. And if I move the arteriovenous structures to the side, we can see that there were bilateral, morphologically left bronchuses with hyparterial bronchi, so that the artery or the first branch of the bronchus is below the branches to the lower lobe. So long bronchuses bilaterally. And if we go back to look at the heart, the arterial trunks are both a bit dilated, but they are normally related, with the aorta spiraling out from behind the pulmonary trunk. And as I said, there were normal branching of the brachiocephalic arteries. Looking at the right-sided appendage, this might be, some people may disagree that this was a left appendage, but you can have hemodynamic dilation of the appendages. And remember, we stated that the pectinate muscles are the most constant component. When we look inside of this appendage, there is the narrow junction. The pectinate muscles are pretty much confined to the appendage. There is no terminal crest associated with this appendage. And there is, though, a prominent venous valve that's remaining. And you can see that the hepatic veins are draining into the right-sided atrium. The oval fossa is actually quite high or more superiorly located on this specimen, and it is probe patent. And there is the coronary sinus, which is important to identify, because we'll see that when we have isomerism of the right atrial appendages, there is no coronary sinus. If we look at the left-sided appendage, we can see that it looks like a left appendage much more than does the right-sided appendage, with the finger-like appearance and the narrow junction to the venous component. The pulmonary veins all drained back to this left-sided atrium, aside from the left upper pulmonary vein, which drained to the coronary sinus, and the right upper pulmonary vein, which drained back to the superior cable vein. This is the azygos vein, and just below it was that right pulmonary vein. It's been torn. So we have partial anomalous pulmonary venous return of the right upper and left upper pulmonary veins. And I failed to show you that on this side, we have an entirely smooth vestibule as well. When we follow the flow of blood through this heart, we can see quite hypertrophied right ventricle and a fairly normal looking tricuspid valve with maybe mild dysplasia. There's the pulmonary outflow tract. And from this right ventricular view, it's kind of difficult to see, but there was a small ventricular septal defect that we'll see much better from the left. And it was a central perimembranous VSD. The inner heart curvature is inserted normally between the limbs of the septomarginal trabeculation. Pulmonary arteries branch normally to the right and left lungs. And I think the duct is closed. It's ligamentous in this case. I didn't open across the mitral valve because I didn't want to destroy the partial anomalous pulmonary venous return to the coronary sinus. So I've just opened the left ventricle in clam-like fashion. You can see the mitral valve is here. It is a bit stenotic, and the left ventricle itself is a bit hypertrophied. When we look up here at the aortic root, there is our small ventricular septal defect. And you can see that there is some of the tricuspid valve tissue kind of herniating in through the defect and into the left ventricular outflow tract. There is kind of a prominent septal ridge here, and as well, no, there's no muscle between the tricuspid and, or the mitral and the aortic valve. But there is a very shallow fibrous continuity, area of fibrous continuity. So increased muscular support relative to the aortic root. And so there was some aortic valvar stenosis. And if we follow the aorta out, we can see that there was a coarctation, hypoplasia of the aortic arch that has a stent in place. So there is a stent here that's been partially endothelialized, but it extends from there to there. So this is one of those cases with isomerism of the left atrial appendages that has a fairly normally formed heart with a ventricular septal defect. These cases will typically show up with arch hypoplasia or a coarctation. We do have symmetric lungs and bronchial pattern and no spleen in this case, even though it exhibits isomerism of the left atrial appendages. And I think Professor Anderson mentioned Dr. Imura, who did a study on looking at atrial appendages and the constant morphologic features. And he also looked at the history of all the patients he looked at relative to whether they had a spleen, had multiple spleens, and a whole other number of morphologic features. And if you put in his name, that paper will come up. It's EUMRA, I believe. And Bobby,
UEMERA.
Yeah. So you will see the charts in there of all the characteristics that he found in all of the isomeric hearts that he looked at. And it's quite impressive that, you know, you can have a good number of hearts with left isomerism that don't have a spleen, that have a single spleen, or that have multiple spleens. So there is a wide range of how these things go. Oh, I did this autopsy a long time ago, so I don't remember. I do know that the one case I have with the organs attached is a fetal death in utero at 26 or 28 weeks, but otherwise I'm not sure. Sorry. So this specimen, we also look at the shape and the position of the heart within the chest, and you can see that this heart kind of almost has a rectangular appearance. So the apical component was kind of flattened. The arterial trunks are again arising in normal fashion from the ventricular mass. Looking at the lungs, bilateral bilobed lungs. This case did have multiple spleens, which I don't have. But you can see there were bilateral morphologically left bronchi or bronchuses. One is opened and one is not. But you can see that, well, they're not as remarkable as in the other case, but there are, the bronchial pattern does exhibit hyparterial bronchuses. And from the back, we can see that there is ipsilateral pulmonary venous return. So the right lung is returning to the right-sided atrium, and the left lung is returning to the left-sided atrium. The appendages are a bit disrupted in this particular case, but you can see that this right-sided appendage was a tubular appendage. The narrow junction has been cut across. The left-sided appendage also is finger-like and has a narrow junction with the venous component. And when we look inside, some of the pectinate muscles are spilling out. but there is a coronary sinus. And the atrioventricular valve is a common atrioventricular valve with the bridging leaflets fused to one another across the crest of the septum. So this was a right dominant common atrioventricular valve. And you can see the increased trabeculations within this right ventricle. There were concordant ventriculo-arterial connections with the pulmonary trunk arising from the right-sided, morphologically right ventricle. And when we look from the left, there you can see the valvar leaflets adherent to one another across the crest of the septum. There is basically a common atrium, so there is no remnant of the atrial septum. And on this left side, we can appreciate a smooth vestibule. There is the left-sided left ventricle with some increased trabeculations, but not as remarkable as the right side. And the aorta did come from the left ventricle with a left arch and a widely patent arch. So the pulmonary veins, as I mentioned, are returning back to each left atrium from each lung. So the right lung to the right-sided left atrium and the left lung to the morphologically left-sided left atrium. The caval vein anatomy, which I failed to mention, we see the superior caval vein was coming to the left-sided atrium. There is no caval vein to the right-sided atrium. And the inferior caval vein was coming from the left-sided atrium. So I have some really nice hearts to show you the venous variations in some of these specimens. So this specimen will show us quasi-normal veno-atrial arrangement. So even though there are bilateral morphologically left appendages, the venous structures are draining to the proper side, even though to a morphologically left atrium. So looking from the front, we can see this tubular appendage with a narrow junction. The atrium is dilated. This left-sided appendage, again, is tubular with a narrow junction to the venous component. The arterial trunks show us that the aorta is anterior to the pulmonary trunk with normal branching pattern, and I think there was a left-sided aortic arch. When we look at the heart from behind and assess the venous structures, here is the right-sided superior caval vein and the right-sided inferior caval vein. So the caval veins are on the correct side of the body, but draining to a morphologically left atrium on the right side. Here is a big azygous vein that was cut, but you can see it was connecting with the superior caval vein. So I can surmise that there was azygous continuation of the inferior caval vein in this case, which is typical with multiple spleens. You can see here the right pulmonary veins and the left pulmonary veins are draining to the left-sided morphologically left atrium. So we have quasi-normal venous connections. So the venous connections are connecting with the appropriate side of the body, but to bilateral morphologically left appendages. When we look inside of this right-sided atrium, you can see the narrow junction. There are pectinate muscles spilling out onto the atrial vestibule, but the majority of the vestibule is smooth, and we see a coronary sinus. When we look at the opposite atrial vestibule, it is smooth with the most of the pectinate muscles confined to the appendage. There's the narrow junction. And here is the left side of the flap valve. So it was slightly deficient. So a small atrial septal defect. And there, if we look at this on short axis, look at the turbeculations of both ventricles. So this is quite impressive with increased turbeculations in both of the ventricles. So here, if we follow the flow of blood, or if we look at the ventricular anatomy, this is a left-sided morphologically tricuspid valve. You can see that there is a subarterial infundibulum. So this is a left-sided morphologically right ventricle that is connected to the aorta in the outflow tract. So there is transposition. In the opposite ventricle, the right-sided ventricle is consistent with a mitral valve. There are no attachments to the septal surface and only papillary muscle support. And this is connecting to the pulmonary trunk. And I'm up through the ductus right now. So that we have a heart that has bilateral morphologically left atrial appendages. So the connections are biventricular and mixed. We have quasi-usual venous arrangement or drainage. And we have a right-sided morphologically left ventricle and a left-sided morphologically right ventricle with transposition. So quite complex, but if you describe all of these things, it's easy for everyone to understand. And if you look at the position of this heart, it actually has quite a funny shape. It's more like sausage-like. It's kind of elongated right to left. And I'm not sure if that's related to the trabecular component or not, but you can still see the coronary arteries following the septum towards the apex. So quite a flat apex.
Can I make a comment on that one, Diane?
Yeah.
That's a beautiful specimen, and at first sight, you might be the inclination would be to diagnose that as congenitally corrected transposition. But in fact, it's left isomerism, and it's obviously a close cousin to congenitally corrected transposition, since, as you say, you have the quasi-usual venous return, you have left-handed ventricular topology, and you have an anterior left-sided aorta. But the other thing that is going along with it being left isomerism is that excessive trabeculation. And that is what has previously often been called non-compaction. It is not non-compaction, it is excessive trabeculation. And we know that that is an association with left isomerism. It's a beautiful specimen, and you demonstrated it exquisitely. That's very interesting. I've seen pictures of that before, but to see the heart itself is amazing. That's beautiful.
Yeah, and thank you for reminding me that I need to mention topology in these cases, because that is actually quite an important feature. So here is the septal surface. So in this specimen, or in any specimen, we typically use the right ventricular septal surface to assess topology. But here, I can only put the palm of my left hand on the inlet or on the septal surface with my thumb in the inlet and my fingers in the outlet. So as Bob said, this is left hand ventricular topology.
And I think the ventricular septum is intact, is it not?
Yes, it was.
So it would be very interesting to know what the conduction system is going to be in that heart. I would imagine that there would be an anterior node as in eugenically corrected transposition, but there could well be a sling in that particular heart. So it's a beautiful specimen. If you ever get to do hip CT, to do synchrotron imaging, that would be a great art to look at with synchrotron imaging.
Maybe once they get the system set in Chicago, we can do some of that.
Absolutely, and that's a beautiful specimen.
It is. It's very pretty. And I actually took that specimen to Andrew's senior marine biology class and did some comparative anatomy with some of the animal hearts that Dr. Van Meerop had to show that, you know, that the excessive trabeculations can exist in the human just as they do in some of the animal hearts. So that was quite cool to show that specimen. So this is another hypoplastic left heart, and you can see there was a pacemaker in this heart. The apex was pointing to the left, or to the right, excuse me. So this is the diaphragmatic surface. When we look at the appendages,
Diane, I think you said, Diane, do you really mean hypoplastic left heart or left isomerism?
oh, sorry. I guess my brain is getting a bit tired.
You're doing well.
I meant left isomerism, sorry. So when we look at the atrial appendages, again, we have some hemodynamic dilation of the left-sided appendage in this heart as opposed to the right-sided appendage as we saw in the last heart. But you can see that the appendage is finger-like. There is a narrow junction to the venous component. The other appendage, again, is finger-like on the right and a narrow junction to the venous component. When we look at the venous component, I'll go from the back. Here we can see the superior cable vein draining or joining the roof of the left-sided, morphologically left atrium, and the inferior cable vein joining the floor of the left-sided, morphologically left atrium. My probe is actually in a large azygous vein, which is now to the left. And on the last heart, we saw the azygous vein to the right. And you'll note that I'm not calling it an azygous and a hemiazygous because these veno-atrial arrangements are quasi-mirror image. So I'm just calling it an azygous vein. So there was interruption of the inferior cable vein. Here are the pulmonary veins, which look like they are draining to this left-sided atrium, but they are actually have more affinity for the right-sided atrium. There was a common atrium in this case. Also, there is a persistent right superior cable vein, which is now draining into the coronary sinus, which is in the atrioventricular groove. So this is quasi-mirror imaged atrial or venous drainage in a heart with isomerism of the left atrial appendages. There was also hepatic veins that drained into this right-sided morphologically left atrium. And when we look inside of the atrium, it was a common atrium, and there is the mouth of the coronary sinus, which if I put a probe in it, I come right out of that right-sided persistent right superior cable vein. There was a common atrioventricular junction and a common atrioventricular valve. So you can see the superior and inferior bridging leaflets, the right-sided ventricle and the left-sided ventricle. We'll look at those ventricles now so that
Diane,
yes,
just go back and show it them again and flip that. Look how smooth, beautiful. Now you see that smooth vestibule.
Yes.
And that is the giveaway that we're dealing there with left isomerism. You look down and look at that smooth vestibule, and now look at that narrow neck of the appendage. That's beautiful.
Yeah. So even though it's hemodynamically dilated and it looks like there's a broad attachment to the venous component, very good point that you make that I forgot to make, that the atrial vestibule is smooth and there is our narrow junction of the appendage. And sometimes with hemodynamic dilation, you can get some of this pectinate muscle spilling out a little bit onto the atrial wall. This atrial appendage is not opened because of the crossing of the persistent right superior caval vein, but we can look at the ventricles at this point. So if we look at the arterial trunks as they are leaving the ventricular mass, they look like they are spiraling in normal fashion with the pulmonary trunk here and the aorta here. When we look at the ventricular mass, this left-sided ventricle has increased trabeculations. The right-sided ventricle also has increased trabeculations. So looking at the right-sided ventricle, we see the common atrioventricular valve. So there's the inferior bridging leaflet, superior bridging leaflet, and now we see that there is a subpulmonary muscular infundibulum supporting the pulmonary trunk. And when we look at the left ventricle, it is a bit more hypoplastic relative to the right ventricle, but you can see the inferior and the superior bridging leaflets and the scooped out ventricular septum. And there is the small mural leaflet and the aortic valve is at the roof of the left ventricular outflow tract, so that there are concordant ventriculo-arterial connections, biventricular and mixed atrioventricular connections, left isomerism with quasi-mirror image venous drainage, apex to the right, and increased trabeculations in both ventricles. And of course, the unbalanced atrioventricular septal defect. So this is a pacer wire on the epicardial surface of this left-sided, morphologically left ventricle. So just two nice cases that show us how the venous drainage can vary in these specimens from heart to heart.
Just bring that one back again for a moment, Diane.
Okay. Yep.
Because here again, we have a problem with, because you've got mirror imaged atrial arrangement and you've got left-handed ventricular, you've got quasi-mirror imaged venous return, and you've got right-handed ventricular topology. So again, there would be you would try to describe this as discordant atrioventricular connections, but in fact they're mixed atrioventricular connections because it's left isomerism with right-handed ventricular topology, but with quasi-mirror imaged venous return. So it's not mirror imagery. As you've shown, it's a beautiful example of left isomerism. So this is why it's so important to diagnose the atrial segment on the basis of the atrial appendages and not on the basis of the venous return. Those are two beautiful specimens emphasizing that point, because potentially if you diagnose this as discordant atrioventricular connections, you would then be diagnosing the next one as concordant. They are concordant ventricular arterial connections, but it's very rare to find discordant atrioventricular connections with concordant ventricular arterial connections and spiraling of the arterial trunks. So this is a lovely example of left isomerism with left-handed topology and concordant
right-handed.
With right-handed topology, rather, yes, and then with concordant ventricular arterial connections. Another beautiful specimen.
And thanks for reminding me about the topology again. Sorry, I forgot that.
Could I, oh, here.
No, by the anatomy of the atrioventricular valve and the septal structures, So here you can see there is a subpulmonary muscular infundibulum. The septomarginal trabeculation is not well seen because most of it's cut away over here. The septal surface and the trabeculations are a bit more coarse in the right ventricle, even though they are increased. And in the left ventricular side, you can see that there is a smooth septal surface towards the outlet, and the papillary muscles are here and here, very hypoplastic, but the papillary muscles and the septal structures are what I'm using to define ventricular morphology. So the increased trabeculations within this left ventricle are even finer than what we see in the increased trabeculations on the right. So like we've discussed this last couple days, is the apical trabecular component is typically the morphologic determinant.
And it's another beautiful example of excessive trabeculation, because in both ventricles you've got a well-formed compact layer, but then you have excessive trabeculation. And this is not, we should not think of this as non-compaction. In fact, it's excessive trabeculation. You can see the compact layer is well-formed in both ventricles, but then you've got an excessive layer of trabeculation. Beautiful specimen. And we know, again, that excessive trabeculation is a feature of left isomerism, pointing again to the fact that this is left isomerism.
I would like to ask a follow-up question just to make sure, you know, the cardiologists, but especially the trainees, have the topology, have understood and internalized the topology method. It is the topographic right ventricle that we use for that. Is that correct? So we use the ventricle that's on the right side of the patient, where we place our hand with the fingers in the outflow and the thumb in the inflow. Is that correct?
It doesn't matter what side the ventricle is on, but we use the morphologically right ventricle as to measure topology. So this is a normal heart. You can see I can only put the palm of my right hand on the septal surface with my thumb in the inlet and my fingers in the outlet. But if we look at the left ventricle, you can see I can put my left hand on the septal surface with my thumb in the inlet and my fingers in the outlet. So each ventricle exhibits normal topology in this normal heart. But when we're looking at congenitally malformed hearts, it is the morphologically right ventricle that we use to measure or judge topology. Is that correct, Professor Anderson?
You don't have did you bring with you a patient heart with congenitally corrected transposition?
No, I did not.
But you have that, isomerism heart you showed, the penultimate one, which has left-handed topology. So you could show the right ventricle on that heart, which is left-sided, but which takes the palmar surface of your left hand, if you show them that again.
Yeah, so this is the left-sided morphologically right ventricle. The subpulmonary infundibulum is here, and the septal surface would be extending in this direction. So only my left hand can fit on the septal surface with my thumb in the inlet and my fingers in the pulmonary outlet. So it is a left-sided, morphologically right ventricle, but with left-handed topology.
Or what the Van Praguists would call that L-looping, because in this instance, the morphologically right ventricle is indeed left-sided.
My other question is, even though it's maybe not it may be a variable feature, but a lot of times we think of the ostium of the coronary sinus as on the sort of receiving atrial end as a typical feature of a right atrium. Yet the coronary sinus itself is often associated with a morphological feature of a morphological left atrium. So does that imply that oftentimes in left atrial isomerism, I have a coronary sinus, but I don't have an ostium on the other side because it's unroofed?
That is absolutely correct. Correct, indeed, and you make a very good point there. Oftentimes, sometimes when you have left isomerism, both of the caval veins try to be coronary sinuses, and both can show features of unroofing, and that's an excellent point you make. And of course, when you have right isomerism, you never have a coronary sinus. So the very finding of the coronary sinus is indicative that you don't have right isomerism.
And this next little heart actually shows that very nicely with the bilateral superior caval veins that we have here. So this was an intrauterine fetal death, I believe, at 26 weeks, maybe 28, I can't totally remember. But it's a very nice case to show all of the organs and the relationships that we can sometimes see, or the variation. So here, this liver is mirror imaged. So the larger lobe is to the left, the smaller lobe to the right. This is where the umbilical vein or the venous duct would come in. When we look at the intestine, the bowel is poorly fixed and poorly rotated. So the ileocecal junction and the appendix were in the mid-upper abdomen. The gallbladder was to the left. The stomach actually wrapped itself around this little lobe of the liver and was left-sided. So the stomach is following suit with being on the correct side. As are the spleens. So here there is 1, 2, 3, 4 spleens. And the hallmark of multiple spleens, rather than just a plain old accessory spleen, is that they occur on both sides of the dorsal mesogastrium. So you can have 2 big splenules and multiple small ones, but if they're on both sides of the dorsal mesogastrium, that will for sure diagnose multiple spleens. So the spleens were on the left. I'm not sure where the pancreas is in this case, but you can see that there is marked maceration of both kidneys. They're very dark red. And if we look at the venous abnormalities, this is the esophagus that I will fold back. Here is the aortic arch, which was left-sided and connected to the left-sided superior caval vein is a left-sided azygous vein. So there was interruption of the hepatic portion of the inferior caval vein with azygous continuation of the caval vein to the left-sided superior caval vein. The lungs were bilaterally bilobed with long hyparterial bronchuses, so symmetric lungs and bronchuses. And when we flip this over to look at the heart itself, again, we have some hemodynamic dilation of the atrial appendage on the left, but clearly a finger-like scalloped appendage with the narrow junction to the venous component. We have a left-sided superior caval vein that I showed you had azygous continuation connecting with that left-sided superior caval vein, and the hepatic veins are draining to the left-sided, morphologically left atrium. Looking at the ventricular mass, the apex was to the right. And when we look at the right-sided, morphologically left appendage, again, tubular with a narrow junction to the atrial component, and it had a right-sided superior cable vein. So that where this cable vein joins the roof of the atrium, you can see this little flange of tissue here, which is where the wall of the right-sided superior cable vein got interrupted. And as you just described, it mimics unroofing of the coronary sinus. So this was virtually a common atrium. The pulmonary veins returned from the right to the right-sided morphologically left atrium. And on the left, they also returned to the right side of the atrial septal component. So here we can see, I'm sorry that this is so dark. Let me see if I can get a little closer. So when we look at the atrial component, the atrial vestibules are smooth all the way around. This is the oval fossa. There's a small little defect. And this is the leading edge of the atrial septum, so that the left pulmonary veins are coming to the right side of that atrial leading edge of the atrium. So right-sided pulmonary venous drainage. So this heart is actually showing us the quasi-mirror imaged venous drainage that we saw in that one heart that I showed you earlier. So here, there is an unbalanced atrioventricular septal defect. This is the left component. It's quite small, and the bridging leaflets are adherent to one another across the crest of the septum. We can see that there again is increased trabeculation within this left-sided morphologically right ventricle. If I place my hand on the septal surface, it can only be my left hand with my thumb in the inlet and my fingers in the outlet. So the pulmonary trunk is coming from this morphologically right ventricle. There is a subpulmonary infundibulum. And if we look at the arterial trunks as they exit the ventricular mass, they are spiraling in mirror imaged fashion. The left atrioventricular junction I did not open because of the unbalanced nature of the atrioventricular septal defect. But when we look into that right-sided morphologically left ventricle, you can see again there's increased trabeculations, and there was significant subaortic stenosis. It is quite difficult to get out this subaortic outflow tract. So I have gone in retrograde fashion in this case. I don't have it opened, I don't think. But it's difficult to get out into the aorta. There we go. So there was aortic valve hypoplasia, and you can see that there was a hypoplastic aortic arch. So a nice, really nice case of isomerism of the left atrial appendages, and this actually shows nicely the comment that was made about the persistent cable vein mimicking an unroofed coronary sinus. And you can see that little flange of tissue there that is marking where that superior cable vein should have had a wall that was coordinating it off to drain to the coronary sinus, but in this case, it is unroofed.
Diane, there's a couple more questions here.
Yeah.
My question is, you pointed out, and the same is true in this heart, that a lot of times left atrial isomerism is associated with left heart obstructed lesions, often an unbalanced RV dominant AV septal defect, often coarctation, sometimes even HLHS. Whereas we often think of things like, tetralogy of Fallot, maybe with a balanced AVSD, sort of as a poster child of the defects we see in right atrial isomerism. Why is that? Why are they so on such different ends of the spectrum for left versus right atrial isomerism?
I am not quite sure what the developmental issues are, but I just know that it more often right isomerism has the most complex constellation of abnormalities than left isomerism. Like the first heart I showed you had concordant ventricular arterial connections without increased ventricular trabeculations, a small VSD with subaortic stenosis, and the stented coarctation. So these cases, in my experience, that have left isomerism can go from very much looking quite normal heart-wise to quite abnormal, like we see in this little heart. I'm not sure if Professor Anderson has any comments on why isomerism of the right atrial appendages is much more complex than the left, and why we get such a mild to severe constellation in left isomerism.
It's a very good question, and I don't think we really know the answer to it, but I pointed out in the presentation I gave yesterday, during cardiac development, it is morphologically leftness that is the default option. So PITX2 is the prominent gene, and the PITX2 is what makes the left side of the heart morphologically left. And so we could argue that leftness is closer to normal than is rightness. I mean, that's, again, very speculative. But and the isomerism, as I also point out, only involves the atrial chambers. So if leftness is dominant, then perhaps that's why although that doesn't really hold good, because when you look at the overall numbers of patients with isomerism, there are as many probable left isomerisms as right isomerisms. But that's the best I can do. I don't think there's a good answer to that at the moment. It's a very good question. Lots of questions are coming up that we don't have good answers to.
Diane, as a morphologist, how do you define ventricular imbalance? What criteria do you use for?
Better question.
Well, you mean with AVSDs or just in general?
Yeah, because clinically we have some criteria based on the valve distribution, right? They talk about the AV valve index.
Well, and as we mentioned the other day when we did AVSDs, the atrial septal and ventricular septal alignment and malalignment are also features that you look at to determine dominant left component or dominant right component relative to the atrioventricular valve. So right dominant, the atrial and ventricular septal structures are aligned, whereas in most cases with left dominant, they're malaligned. But I have sat in on several clinical conferences where you can clearly see by echo and CT that it's a right dominant AV septal defect, but with septal malalignment. So it does occur. I'm not sure if you have any other comments, Professor Anderson.
I think it's very difficult for them. I think it's easier for the clinicians these days to work out, to make the measurements. It's very, I mean, Diane, you're not a great measurer, are you, Diane?
Measure of what?
Of
Look,
dimensions.
in
I mean,
every-
I
Well, in every autopsy, I measure atrioventricular valves and
Okay.
arterial valve circumference and ventricular thicknesses. So we do a certain amount of measurements, but I don't know if I can clinically measure how much blood is going through those ventricles, and if it's going to grow enough to become equally dominant when you have a smaller left ventricle to begin with. So
I've never been a great measurer myself, so I think the answer that I would give to left, how do you know it's dominant? You eyeball it. It looks right dominant, or it looks left dominant, and in many instances the diagnosis has already been made, hasn't it? During the clinicians have made the diagnosis, so when we come to autopsy, we're seeing the outcome. So I think it's I think it's harder for the morphologist to make to give a solid diagnosis based on measurements, or at least for me. But have you ever tried to correlate the measurements you make with the measurements that are made during life?
Sometimes when we have our mortality morbidity conferences, we do discuss those things. And the last 5 years, sitting in on conferences that are dealing with live patients as opposed to the patients I deal with, it's amazing the discussion that goes on between people with different opinions as to what's hypoplastic and what's not, and what's balanced and what's not. So it's been particularly enlightening for me, looking at things on the pathologic spectrum to see the clinical discussions.
I think
And a
it's
lot of
another
people
very
are
good
chuckling,
question.
so
It's difficult. I still think it's very difficult for the morphologist to make that distinction. So we'll stick with the clinicians.
all right, so I guess we can move on to a little more complexity and look at some isomerism of the right atrial appendages. And so this was an explant, and this patient had a markedly dysplastic common atrioventricular valve. And you can see that even after transplant, I can still diagnose the presence of right atrial isomerism, because you can see a pretty much triangular tip to both of these atrial chambers, but the pectinate muscles are clearly seen all the way around both atrial vestibules to the crooks of the heart. So just a nice example, like I showed you in left isomerism, from the short axis at the base. And there was pretty much clinically a common atrium in this case, so that there was only an atrial strand dividing the atrial chambers. And echocardiographically, this is that little dot that you guys see floating out there in the black space, where that atrial strand comes across the virtually common atrial chambers. This specimen, as I said, had this very dysplastic common atrioventricular valve. The right ventricle was extremely hypertrophied, and this case had the tetralogy variant of double outlet right ventricle with a prominent outlet septum, subpulmonary stenosis, and the aorta anterior and to the right of the pulmonary trunk, but both arising 100%. So 200% arising from the right ventricle, so double outlet right ventricle. And there was a very thin subaortic muscular infundibulum. So complete muscular infundibulum supporting both arterial trunks. And when we look at the left component of this common atrioventricular valve, again, you can appreciate the dysplastic nature. And look at this left ventricle. Even though it looks as though it reaches the apex, it still appears much smaller cavity-wise than did the right ventricle. quite hypertrophied as well. So just a nice example of isomerism of the right atrial appendages. And this case, actually, I should mention the topology had right hand topology. So only my right hand can go on the septal surface with my fingers in the or my thumb in the inlet and my fingers in the outlet. So I think I only have one case that I brought that shows the quasi-mirror imaged venous drainage, because I didn't have one in right isomerism that showed usual arrangement. I know we had a couple cases at the Lurie Children's Hospital that showed us both quasi-usual and quasi-mirror imaged. So I brought this one that shows us the quasi-mirror imaged arrangement. You can see that the apex of this heart was to the right. This is the diaphragmatic aspect. Here is the aorta, and directly posterior to it was the pulmonary trunk. If we look at the right-sided morphologically right appendage, you can see that it has a blunt or triangular tip. These are actually, this is a hepatic vein draining to this atrium. And well, maybe this one isn't what I thought it was. Yeah, the pulmonary veins in this heart are draining elsewhere. So most likely below the diaphragm, because they're not attached to this specimen. But you can see that the inferior cable vein was attached to the left-sided atrium and the superior cable vein to the right-sided atrium. There was a left or a right brachiocephalic vein extending from the left-sided superior cable vein, and you can see that the left-sided morphologically right atrium is also having a triangular tip and with a broad junction with the venous sinus. So the cable veins are left-sided in this particular specimen with anomalous pulmonary venous drainage. So if we open this left-sided morphologically right appendage, there are pectinate muscles there extending to the crooks. You can see them here with my forceps spreading them. And there was a terminal crest crossing the opening of the superior cable vein. You can see it starting here. When we look at the opposite side of the atrial appendage, again, the terminal crest has been cut a bit, but it is right here along the edge, crossing the junction of the atrium to the atrial wall. And there's the hepatic vein, but there were also pectinate muscles extending all the way to the crooks. And there is no coronary sinus in this case. There was a common atrioventricular junction. So there's the leading edge of the atrial septum. And there are a few fenestrations in the flat valve, which is actually quite small in this case. When we look at the ventricular mass, Dr. Van Meerup kind of sliced across it, but you can see the aorta was left-sided and anterior relative to the pulmonary trunk. And when I remove the ventricular mass, you can see that the right-sided ventricle was consistent with a morphologically left ventricle with its fine crisscrossing apical tuberculations and the smooth septal surface towards the outlet. So this was a common atrioventricular junction with virtually a double inlet left ventricle. This is the interventricular septum. And here was the interventricular communication and the hypoplastic morphologically right ventricle. So there was pulmonary atresia in this case, with the aorta arising from the hypoplastic, morphologically right ventricle. So this case would have, I guess, I'm trying to figure what topology this would be. So I can put my right hand on the septal surface with my fingers. There is no inlet towards the inlet component with my thumb in the outlet. It's a double inlet left ventricle.
You would presume that it's left-handed topology because the incomplete right ventricle is carried on the left shoulder of the heart. But you're right, it's harder to use topology when you don't have an atrioventricular valve coming into the incomplete left ventricle.
Yeah, so with isomerism of the right atrial appendages, you will always have anomalous pulmonary venous return, even if the pulmonary veins are returning to the atriums, because the pulmonary veins are returning to morphologically right atriums. Yes. Well, it was the only outlet to the heart because there was pulmonary atresia. So it had most of the preferential flow.
Professor Anderson, would this be a good opportunity to talk about your affection for the term bulboventricular foramen?
No.
It's a ventricular septal defect. I hope you don't still talk about the bulboventricular foramen. I think that's
but there are, you know, it's like MRSA colonization. There's only so much you can do.
But once we accept that in this heart we have a dominant left ventricle and an incomplete right ventricle, then obviously the communication between the two is a ventricular septal defect. So QED. But
there are people at my place who still use the term bulboventricular foramen. And so I've prepared a short PowerPoint that I sometimes will flash up and show them some developmental things that why it is not a bulboventricular foramen. So I have a number of right isomerisms here, and I'm just going to go through them because I'm not quite sure who is who at this stage, because I didn't have a lot of time to get situated here. So we're just going to kind of go through all of the anatomy. So looking at this particular specimen, the apex of the heart was to the right. There were bilateral trilobed lungs. The aortic arch was to the right. And you can see nicely here the bilateral morphologically right bronchuses. The pulmonary arteries have unfortunately been cut in this particular specimen, but I think you can see maybe one branch here, so that the bronchial tree is eparterial, and they are short bronchuses. Very nice symmetrical pattern in this case. And this is the pulmonary venous drainage, so that both pulmonary veins are attached to this very thick vein that was extending below the diaphragm. You can see the upper veins here joining to this confluence and the lower veins here. And as many times as I tell people who eviscerate, if there is right isomerism, you must leave the abdominal organs attached. It doesn't always work. So I can't give them an answer as to where this went, aside from below the diaphragm. Looking at the cardiac anatomy, on the right side, we can see this morphologically right atrial appendage with its blunt tip and a broad junction with the venous component, so that there was a right-sided superior cable vein and a right-sided inferior cable vein. Looking into the atrium, there is an atrial septal defect with a deficient flap valve at the floor of the oval fossa. When we look at the opposite atrium, here is the tip of the appendage. There's a broad junction with the venous component. Here is the left-sided superior cable vein. And there were also hepatic veins draining into this left-sided atrium. You can see the flap valve at the floor of the oval fossa. And so when we look at these atriums opened, the pectinate muscles on this left-sided atrium aren't so impressive, but there are a few here extending to the crooks of the heart. There is a terminal crest here. And the opposite atrium on the right, you can see the terminal crest here. And there is no coronary sinus. And again, there are the pectinate muscles here extending to the crooks. This case has an atrioventricular septal defect. As I mentioned, there's a deficiency at the floor of the oval fossa with the flap valve. And there you can see the atrioventricular septal defect, so that the bridging leaflets are free floating over the crest of the septum. Very hypertrophied right ventricle, morphologically right ventricle. And you can see that the aorta is arising from that morphologically right ventricle. There are coronary orifices here. There's one there. Actually, they may be side by side, both from the same sinus. A slit-like, there's one there, but there is a very small slit-like one right here that's hard to see. And when we look at the branching pattern from the aortic arch, it's a right arch with mirror-imaged branching. And looking for the pulmonary trunk, it was atretic. No, it's very tiny. There it is.
That's
So-
amazing.
You can see why it was hard for me to find, but it was the branch pulmonary arteries were supplied by this duct that got cut from the underside of the aorta, and this tiny pulmonary trunk was joining just here, where it tore apart from the ventricular mass.
That's a lovely example, Diane, as to how difficult that would be to diagnose during life from a solitary arterial trunk.
Correct. So these cases can be quite complex, and to just go back and look at the topology of this right ventricle, it was right hand topology, only my thumb in the inlet and my fingers in the outlet. When I do the autopsy, I remove the thymus with the pericardial sac and then dissect the sac off and weigh the thymus. Yeah, well, sometimes it's there, but it is just two little thin parallel lobes that are laying atop the brachiocephalic vein and attached to the pericardial sac. Sometimes I just see a couple little nubbins up in the neck, so hypoplasia of the thymus in some cases. I don't know how echogenic they would be if they're very thin, two little slivers of thymus, but it is variable, especially in cases with congenital heart disease. I mean, of course, normal cases they just hangs right there over the arterial trunk. So no, and that's one thing we look for is the thymus too, and we always weigh it. I do weigh things, Bob. So this is another case of isomerism of the right atrial appendages. You can see the apex is pointing to the left. This case did have some type of surgical intervention. Actually, there's a Blalock-Taussig Thomas shunt, modified shunt. And here, if I stretch out the caval veins, you can see there was a nice brachiocephalic vein, which is, in my experience, typically not the case when you have a left superior caval vein, unless it's in the case with atresia of the coronary sinus, as I showed in the grand rounds presentation. But here we see there's a good sized brachiocephalic vein. The aorta is right anterior on the ventricular mass. And this case also has or had a very tiny pulmonary trunk. So there is the pulmonary trunk that got torn away or detached from posterior to the aorta. And you can see that the Blalock-Taussig Thomas shunt was attached to the right pulmonary component. And there's the common pulmonary trunk there in my forceps. So if we look at the right-sided, morphologically right appendage, here we see the blunt triangular tip, the broad junction with the venous component. Looking at the opposite side, there is our persistent caval vein, which you can see had some pulmonary venous drainage going to it. Maybe the reason that there was a retained brachiocephalic vein because there was extra drainage. The appendage is quite small, and the attachment with the venous component has been kind of disrupted because they've replaced or repaired the pulmonary veins, put them back into the left-sided morphologically right atrium. And if we follow this structure here, up underneath the pulmonary artery, you can see that there was a vertical vein extending up to the brachiocephalic or to the persistent left caval vein, so that there was total anomalous pulmonary venous drainage above the diaphragm to a vertical vein that was passing between the bronchus and the pulmonary artery. So probably mimicking a bronchopulmonary vice. You can see where the confluence was coming behind the heart and where they reinserted the pulmonary veins into the left-sided atrium. You can see the sutures there. So this atrium is not open. But when we look inside, there is an atrial septal defect, so deficient flap valve. The pectinate muscles are not very prominent. A few here. There was a common atrioventricular junction. Again, this was a right dominant situation. But you can see the pectinate muscles within this left-sided atrium extending here to the crux through the ASD. There was no coronary sinus. And when we look at the right ventricle, it is extremely dominant in this case. That little blood-filled space is, I believe, where the left ventricle was, or the left component of the common AV valve. And in looking for this tiny left ventricle, I didn't look very hard because sometimes it's disruptive to the specimen, but there was a little endothelial lined chamber just at the tip of my probe. You can see the white area. And so this was extreme unbalanced right dominant atrioventricular septal defect, where sometimes the communication with the left component of the AV valve becomes imperforate at some point, retaining or leaving some blood in that left ventricular side. And I have seen a couple of cases like this throughout my autopsy career. So that this is a case with right-hand ventricular topology. Only my right hand can go on the septal surface, thumb in the inlet, fingers in the outlet. And from this right ventricle is our aorta. And as we saw, there was pulmonary atresia. So we have transposition with pulmonary atresia. There's the left coronary, or the right coronary, sorry. And actually, this case is one that has a solitary coronary artery, a single coronary, which you can also see. So we always make sure that we assess the coronary anatomy in addition to all of the other anatomy. And here nicely, you can see that there were bilateral trilobed lungs and very symmetric, very nice, short, morphologically right bronchuses that are eparterial. So you can see a portion of the pulmonary artery extending to the lower lobe here. So very nice bronchial anatomy in the last couple hearts that I've shown you.
Sorry to interrupt.
Is there a question?
Oh, yeah. Can I just ask a question about right atrial isomerism? You talked about left atrial isomerism and PIDX2, and it seems like it's by default, if the lefty one and notch are not there, you get left atrial isomerism. So how does what is the mechanism by which we get right atrial isomerism?
The genes fail to block, the genes fail. And so the right isomerism is the right morphology or morphologic features are allowed to cross during development. So the lefty malfunctions and does not stop or block the morphologic right genes from
Morphological left gene. Morphological left gene. PIDX2 is morphological
yes.
left.
So this is another heart with morphologically right atrial appendages. I think I have 2 more hearts to show you after this. So again, a blunt atrial appendage with a broad junction to the venous component. The opposite atrium shows us the same thing. There is no cable vein on this left-sided or associated with this left-sided morphologically right atrium. And we can see that on the right, there was a superior and an inferior cable vein associated with the right-sided atrium. There is our terminal crest. and the pectinate muscles here on the right are not very well seen. There's a prominent venous valve here, and this is the oval fossa with a few fenestrations. But nicely, even though the left-sided morphologically right atrium is not opened, you can see how nice those pectinate muscles are extending to the crooks. There is an atrioventricular septal defect in this case as well, with a well-formed oval fossa. And when you look at this case, the way it was opened, it's kind of funny looking, but this is a common atrioventricular valve. And over here on the inferior surface where it was opened, this is the left component of the common AV valve. And you can see this tiny endothelial lined chamber, and there was an imperforate component of the common AV valve. So the opposite side of this hypoplastic left ventricle is not very well seen because it was mostly left on the free wall of the inferior free wall of the right ventricle. When we look at the arterial trunks associated with this case, you can see that it was trying to be a double outlet right ventricle. So here is the aorta arising anterior to where the pulmonary trunk was. There is pulmonary atresia, and both of the arterial trunks in this case were supported by muscular infundibulums, but the pulmonary artery is atretic. Again, in this heart, it was a very tiny pulmonary artery here that was, the branch pulmonary arteries were fed by this kind of curly arterial duct arising from the underside of the aorta. And when we look at the pulmonary veins and the bronchial anatomy, again, we have actually bilobed lungs bilaterally and bilateral morphologically right bronchuses. And the pulmonary veins were returning via this very hypoplastic vertical vein posterior to the bronchus and to the superior caval vein. So you can see why this case has developed. You can see all these nodular areas on the lungs. So there's pulmonary lymphangiectasia and severe pulmonary venous stenosis with this tiny vertical vein draining the pulmonary confluence behind the heart. So this next case, I have all of the organs attached, and the heart is actually quite interesting. It's been repaired, but we can still see the initial anatomy. So looking at the abdominal organs, you can see the liver is mirror imaged with the large lobe on the left and the smaller lobe on the right. And actually, none of those cases that I've shown you already had a spleen. You can see the gallbladder was left-sided. The stomach was right-sided, as was the pancreas. And there is no spleen, which you would typically see associated with the tail of the pancreas and the greater curvature of the stomach. The bowel is malrotated with the appendix in the left upper quadrant. The apex of the heart was pointing to the left, and the pulmonary anatomy shows us a trilobed right lung and a trilobed left lung with only a small component of the inferior or lower lobe remaining. The bronchial anatomy was mirror imaged. So you could see a morphologically right bronchus on the left and a morphologically long bronchus on the right. Looking at the heart, there is a morphologically right appendage to the right with a superior cable vein and an inferior cable vein. On the left, another blunt appendage with a superior cable vein and hepatic veins. Actually, I should check that and see. So I misspoke. The inferior cable vein is to the left and the hepatic veins are to the right. So this is the hepatic or the inferior cable vein, which goes along with the mirror imaged liver. And these are hepatic veins. So from the left, morphologically left atrium, we can see the terminal crest here. And the pectinate muscles from this atrium are not very well seen, but from the opposite atrium, you can see them here, extending to the crooks. When we open that opposite atrium, there are those nice pectinate muscles extending all the way through to the crooks. And we have our terminal crest here. There was an unbalanced, actually, there is a common atrioventricular valve in this case. So this is the primary component of the atrial septum with a few fenestrations. Here is the leading edge of the atrial septum. There was no coronary sinus. So my forceps are in the right-sided atrium. Here's the leading edge of the atrial septum. And you can see the cable vein joining this left-sided, morphologically right atrium. The pulmonary veins were draining to this right-sided atrium. And when we look at the common atrioventricular valve, it's quite dysplastic. The aorta, actually, yeah, the aorta was arising from the left ventricle, the morphologically left ventricle. And there was nearly a complete muscular infundibulum. Actually, there was a complete muscular infundibulum. It's just very, very narrow right here. So aorta arising from the morphologically left ventricle. When we look at the rudimentary right ventricle, it's on the anterior inferior aspect of the heart. You can see that it lacks an inlet, has an apical trabecular component, and an outlet. There is the very large ventricular septal defect, and you can see that the pulmonary valve is supported by a complete muscular infundibulum. So this is actually a good representation of the Holmes heart. So there is a double inlet to the left ventricle with concordant ventriculo-arterial connections. So the pulmonary valve or pulmonary trunk is arising from the morphologically right ventricle and the aorta from the morphologically left ventricle. There was significant subaortic stenosis because there was a posterior deviation of that outlet septum, and along with the subaortic muscular infundibulum. So in this case, they did a DKS. So you can see where they've anastomosed the aortic root to the pulmonary trunk, and then they anastomosed the aorta and descending aorta to the pulmonary trunk. And the pulmonary blood supply is via a left-sided Blalock-Taussig Thomas shunt because there was a right aortic arch with mirror-imaged branching. If I turn the heart over, we can nicely see the anomalous pulmonary venous connection going to that left-sided, actually to the right-sided, morphologically right atrium. So you can see all 4 pulmonary veins draining to the back of the atrium. Often it's to the midline of the atrium, but this one was to the right side of the atrium. And had the unusual finding of the mirror imaged bronchial arrangement. I showed this heart to Professor Anderson the last time he was in Florida because it is quite unusual. So you can see the arterial trunks as they're leaving the ventricular mass. The aorta is anterior and rightward of the pulmonary trunk. They're pretty much side by side. You can see that there was a left aortic arch. Actually, there was a right aortic arch with mirror imaged branching. And when we look at the atrial appendages in this case, the tips of the appendage kind of have a little bit of a finger-like appearance, but looking at the attachment to the venous component, we see kind of a broad attachment. There was a superior cable vein on the right, but no inferior cable vein. When we look at the left-sided appendage, again, it has this little finger-like tip, if you will. But when I stretch the atrium out, you can see that there was a left-sided superior cable vein and kind of a broad area here. When we look at the heart from the back, the cable vein was virtually in the midline, and as well, the right pulmonary veins came into the common atrium just to the right of the midline, and the left pulmonary veins just to the left of the midline. This heart was kind of opened in a clamshell kind of fashion, so somebody almost cut it in a 4-chamber plane. So there was a common atrioventricular junction. This is the inferior bridging leaflet, the crest of the septum, the left ventricle and the right ventricle. And when we look inside of those atrial chambers, here on the right, you can see the pectinate muscles extending towards the crooks. Here on the left, the same thing. There is the inferior cable vein in the midline. And when I stretch the atriums out, associated with each of the superior cable veins, there is a terminal crest. And there are 2 little coronary veins coming in adjacent to or inferior to the inferior cable vein. And there you can see the pulmonary veins returning behind each of those terminal crests. So this case to me was very confusing because both appendages have pectinate muscles extending to the crooks. They have broad junctions with the venous component, but they have these little finger-like tips to each of the appendages. Anomalous venous return. There was a double outlet to the right ventricle. So even though this is cut kind of funny, you can see one arterial trunk here from the right ventricle and the other one from the right ventricle. And when we look at the bronchial and pulmonary anatomy, bilateral bilobe lung on the right, bilobed lung on the left. And when we look at the bronchial tree, there are bilateral hyparterial bronchuses. So there's the pulmonary artery on both sides. And when I showed this to you earlier, Bob, in 2022, I just thought this was so unusual that we had morphologically left bronchuses, but I was unsure if this went with isomerism of the right atrial appendages. I'm still not sure what group or category to put it in. Ipsilateral pulmonary venous return. Are these coronary veins or are they bilateral coronary sinuses? There was a midline inferior cable vein, bilateral superior cable veins, and what looked like pectinate muscles to the crooks on both sides of this common kind of venous sinus. So a very interesting kind of middle of the road. I don't know where to put this heart. So
I think the pectinate muscles are the giveaway, and I think those are coronary veins coming in. I don't think there is a coronary sinus. I think you're right there. I don't remember you showing me that. Perhaps I forgot it on purpose. As I agree with you, that is the closest to the middle of the road I've ever seen, and I don't recall seeing it before. But I think the pectinate muscles are the giveaway.
That's what you told me in 2022. So it's
I'm
just
glad I'm consistent.
Yeah, it's just very strange how there's just this common venous sinus for the pulmonary veins and the inferior cable vein and the terminal crests on either side of it. So
Absolutely.
very interesting. Very
and
interesting
also the
case.
pulmonary veins are very interesting because, as you say, they look very symmetrical. So it is a very interesting heart.
It didn't read the book for either right or left isomerism.
It didn't. Just as well you saved that one for last.
Yeah. Oh no, I'm. What time is the other grand rounds? 4 o'clock. No, I've gotten through the hearts that I brought to show you guys. So I don't know if you have any other comments of. Oh, actually, I do have one heart that I wanted to show you just to prove the point that the pectinate muscles are the ultimate determinant. So I don't want to forget this little guy. So I got this from the surgical bench at UF, and I looked at it quickly, and I thought, oh, look at that nice left appendage to the right, and look at this nice right appendage. This was a transplant, so I only got remnants of the atrial appendages. And so I plopped it back in the jar to photograph the next day, and I thought, what a find. I don't have any cases with mirror imaged atrial arrangement. And the apex of this heart went to the right. So I got there the next day and I put it down to photograph, and I was so disappointed because you can see the pectinate muscles on both sides extending to the crooks of the heart, even though there was a narrow appendage on the right side. Clearly, there are pectinate muscles all the way around, and clinically, this was diagnosed as isomerism of the right atrial appendages. So you can see there was a common atrioventricular junction, but the main point I wanted to make is that you can't always judge the outside of the appendage. You have to look at the pectinate muscles. So sorry I forgot to show you that, but it is looking like mirror imaged atrial arrangement, but it's actually not because of the pectinate muscles. So they are truly the morphologic determinant.
Do we look at cilia at all in, inside the trachea, the tracheal lining for ciliary dysfunction and isomerism?
That typically goes along with left isomerism, the ciliary issues, and I think that is another thing that goes along with azygous continuation and polysplenia or multiple spleens is biliary atresia, which is also one of those ciliary issues. So I know there's been some work done on that, and I think Rohit Lumba, who I know is a cardiac intensivist and also boarded in cardiac or cardiology, and he takes care of the Idris archive. So he's been very interested in doing some research on that. I don't know a lot about that, but I know it's associated with left isomerism.
Question in the chat from Nithya Swaminathan. Quote, is there anything that you see consistently most reliable for left or right isomerism? Is it the atrial appendages or the bronchi, since the spleen is not reliable?
It's the atrial appendages. The bronchial anatomy is fairly consistent, or mostly consistent, but not always. As I showed you, there was one case here with mirror imaged bronchial anatomy and right isomerism.
Go ahead. We're waiting with bated breath.
Professor Anderson, Dr. Marshall Jacobs said hello. I was emailing him for a different reason, and he wanted me to let you know that he's passes his
Good to
regards
hear
to you.
from him. Please send my best wishes back to him. He's a great guy. So all the best
do.
to Marshall.
Thank you.
I think is he still associated with Johns Hopkins, Diane?
I don't know.
He was. I
Oh.
know he was associated with Hopkins, but I don't know whether he came much to. He obviously came a long time ago when we had the old St. Pete meetings, but I
Yeah.
guess he's not been for some time.
He still has their email.
Right.
then-
Well, there you go.
Then he probably is still associated, but I haven't had any contact with him in the recent past.
Well, please give him our best wishes.
All right. What a great
Okay,
session,
folks, I'm
fellows.
going to
We got
bed.
it.
Great presentation again, Diane. Wonderful specimens, and you did well to take them all the way to Oregon. So,
Oh, I'm sorry, I didn't hear that with the clapping.
no, I was saying great presentation, and you did well to bring so many specimens to Oregon.
Oh, well, I could have brought more, but I have to pick and choose sometimes. So.
But well done. See you all tomorrow.
See you tomorrow.